I am Dr. Vidyasagar, Associate Professor in the Department of Pharmacology. Today I am going to discuss on the topic of pharmacology of alcohol. The competency is PH 1.2.1. It is to describe the symptoms and management of methanol and ethanol poisoning. And the specific learning objectives are: first one is to outline the management of acute alcohol intoxication. The second is to explain the toxicity of methanol poisoning and its treatment. Third objective is to justify the use of ethanol and foam episode in methanol poisoning. So basically, alcohol by chemistry, they are aliphatic hydrocarbons with hydroxyl group, and the most important alcohol is the ethanol, which is used as an astringent. Widely they are used in clinical side. They are used to surface the precipitate the surface of the protein. It is used to prevent the bed sores. Also, alcohol is used as a counter irritant. The injections of alcohol is given in the trigeminal neuralgia, and the glycerin is commonly used emollient. Mannitol, which is an osmotic diuretic, used in open angle glaucoma. And methanol, ethylene glycol, both are having used for industrial purpose. Especially methanol is nothing but a wood spirit, and ethylene glycol is commonly used preservative. So apart from the industrial purpose, they are having toxicological importance. Ethanol produces psychological dependence. Ethanol is a strong CNS depressant. It produces craving and makes the patient addicted to the usage of alcohol over long time, compared to the physical dependence, which doesn't produces any craving. For example, caffeine. On long term intake, the patient is abstaining suddenly from the intake of caffeine. It produces withdrawal symptoms and doesn't produces craving compared to the use of alcohol. Alcohol mechanism is, it acts on the GABA receptor, which is nothing but gamma aminobutyric acid. It's a transmembrane receptor. It has different subunits like alpha, beta, gamma, and a channel, intracellular channel it has, through which the chloride ion passes through. Once the chloride ion passes through, it produces depolarization and CNS depression. Coming to the mechanism of addiction, it is based on the brain rewards pathway. Suppose a person is addicted to alcohol, it is due to the release of dopamine from the substantia nigra. On chronic intake, dopamine will be released from the substantia nigra, which gives pleasant signal to the person, which makes him to dependent on it. So dopamine, which is released from substantia nigra, is the key molecule which makes the patient addicted to the alcohol. The metabolism of alcohol is: ethanol is converted to acetaldehyde by alcohol dehydrogenase. This enzyme converts ethanol to acetaldehyde, and aldehyde dehydrogenase is the enzyme which converts acetaldehyde to acetate. Similarly, in case of methanol, methanol will be converted to formaldehyde by alcohol dehydrogenase, and aldehyde dehydrogenase will convert formaldehyde to formic acid. So disulfiram is used for aversion therapy. So on long term usage of alcohol, the patient is addicted to alcohol, so we can use this aversion therapy. So disulfiram is nothing but aldehyde dehydrogenase blocker. So once this enzyme is blocked, the acetaldehyde cannot be converted to acetate. So the acetaldehyde level increases in blood. This results in the headache, dizziness, confusion. So it creates a kind of aversion to the intake of alcohol. So disulfiram is used as aversion therapy for de-addiction of patients who are addicted to alcohol. So it is an aldehyde dehydrogenase blocker which prevents the conversion of acetaldehyde to acetate. Apart from this disulfiram, we can use other opioid antagonists like naloxone, naltrexone, and nalmefene. So these drugs are opioid antagonists which can be used as a de-addiction therapy for alcohol. So alcohol follows zero order kinetics. If you are comparing the first order and zero order kinetics, first order kinetics, the drug will follow the drug will be eliminated in proportion to the plasma concentration, whereas zero order kinetics, the drug elimination won't depend on the plasma concentration. So here the elimination will be saturated in case of zero order kinetics. So the drug level increases in the blood and it results in the toxicity. So as alcohol follows zero order kinetics, once the blood alcohol level increases, the patient may go for loss of coordination, delirium, dementia and other CNS related side effects. Patient may go for coma, medullary paralysis and finally he may pass out. And these are the adverse effects of long term intake of alcohol. You know that alcohol is a CNS depressant, so it produces mainly neurotoxicity. Most important thing is Wernicke-Korsakoff syndrome, that is due to vitamin B12 deficiency. On chronic intake of alcohol, it depletes the intracellular B12 level, so the patient will go for demyelination and the neurotoxic symptoms. So it is collectively called as Wernicke-Korsakoff syndrome. And apart from neurotoxicity, the patient will go for hepatotoxicity. The chronic intake of alcohol will lead to fatty liver disease and cirrhosis. Also the patient will develop endocrine imbalances. He may go for oligozoospermia, infertility and other complications. Apart from this, the patient will get the GI related side effects like gastritis and other things. The patient can go for arrhythmia. So it is a cardiotoxic agent also. The patient, if he is consuming alcohol, if he is dependent on alcohol for long term, he may develop arrhythmia. Another important thing is the patient may develop cognitive memory loss and he will develop dementia on long term. So in case of methanol poisoning, this is very common in case of rural area where patient will accidentally or for a suicidal purpose they will consume this methylated spirit, which is nothing but methanol. If the patient is consuming 15 ml, it may lead to blindness. If the level increases to 30 ml, the patient may go for death. The blood level of more than 50 milligram per deciliter indicates severe poisoning. And these are the general measures for the treatment of alcohol poisoning. First one is to protect the eyes from light, especially in case of methanol poisoning. The formic acid will damage the retina, so we have to protect the eyes of a patient and we have to prevent the direct sun exposure also. Next measure is to maintain the patency of airways. This is to prevent, and also we have to prevent the regurgitation into the respiratory system. In case of acute intoxication of alcohol, if the patient has consumed alcohol in overdosage, we have to do gastric lavage, and here also we have to again we have to assure the to prevent the regurgitation into the respiratory system. And the next measure is to give intravenous infusion of alcohol. This is to prevent the development of hypoglycemia. So along with glucose we can add electrolyte also to prevent any electrolyte imbalance. The last measure is to give vitamin B12. It's nothing but thiamine. The dose is 100 mg IV. So this is to prevent the patient to go for prevent the patient from developing any neurotoxic effects. So the specific measure of treatment is fomepizole. Fomepizole is the specific antidote for methanol. It inhibits the enzyme alcohol dehydrogenase. So this fomepizole, this antidote prevents the conversion of methanol to formaldehyde. So as such, methanol is intoxic. So once the enzyme alcohol dehydrogenase converts this methanol to formaldehyde and subsequently to formic acid, so these metabolites are resulting in toxicity. Otherwise, as such, methanol is not toxic. So this antidote inhibits the alcohol dehydrogenase, which prevents the development of metabolite formaldehyde. And you know this formic acid, which is the final product of this methanol, is the reason for retinal damage, respiratory failure and other CNS depression, respiratory failure, neurological dysfunctions and all this, for all these complications. So fomepizole is one specific mode of treatment, which is an antagonist for this enzyme alcohol dehydrogenase. Another specific measure is to use ethanol. So we have to use ethanol in case of methanol poisoning. What is the reason is ethanol is a competitive antagonist for methanol. So you will be knowing the difference between competitive and non-competitive antagonist. In case of competitive antagonist, both agonist and antagonist will be competing to bind to the same site of the receptor. Whereas in non-competitive antagonism, both agonist and antagonist won't compete for each other to bind to the same site of the receptor. So we are using ethanol here to prevent the methanol to binding to the receptor. So once we administer ethanol, this prevents the binding of methanol to its binding site. So what happens? Methanol will not be converted to its metabolites. So the other measures are to administer bicarbonate. In case of acidosis, we have to administer bicarbonate, and the final measure is hemodialysis. So thank you.